We designed appropriate empiric therapy for HAP and VAP. Now, given microbiological results, let's de-escalate from empiric therapy to pathogen-directed therapy. In general, there are a lot of different types of bacteria, and they could be part of the normal flora, so they are actually essential for the normal human health, or they could be colonized, which means that bacteria that are not part of the flora could actually be in part of like the GI tract, for example, and not necessarily cause an infection and just colonize it. Now, whether colonized or as part of normal flora, bacteria occasionally can have resistant genes. So let's say the red bacteria here are resistant to antibiotics and the blue ones are susceptible. And keep in mind that this is just part of the flora, not necessarily an infection. Now, what happens every time that we use antibiotics is that the antibiotic, while we use it to treat an infection, what it does to the actual flora is that it actually wipes out all the ones that are susceptible to that antibiotic, and the ones that are resistant to that antibiotic will stay behind because the antibiotic could not kill it. Now, again, those bacteria were not really causing an infection, they were just part of the flora. But when we use the antibiotic, we actually selected for them, and now they have the opportunity to become the dominant bacteria in the flora. Or if they were just a colonization, now they become the dominant organisms in the body. And keep in mind that they all have the genes for resistance to antibiotics. Now, occasionally, if someone gets actually infected, what happens is that these bacteria that have the genes, the resistant gene, they can actually transfer it. So they can donate that gene to a pathogen, which will cause drug-resistant infection. This whole process is referred to as selection pressure. Which brings us to the concept of broad versus narrow spectrum of activity. So generally speaking, broader antibiotics are more likely to cause selective pressure because they can wipe out more clinically significant organisms and leaving behind the resistant organisms. Now, when it comes to broad versus narrow, the generally accepted definition is based on gram-negative coverage. It's not so much about a head count, so it's not about how many organisms an antibiotic covers. It's more about which organisms does it cover. So it's about clinically significant organisms. So in order to understand if a drug is broad or narrow, you should ask yourself the following question. Does it cover carbapenem-resistant Enterobacteriaceae? Now, CRE, such as E. coli and Klebsiella, that are resistant to carbapenems, we don't have a lot of antibiotic options for them. So this is one of the most resistant pathogens available. So if we have antibiotics that's active against CRE, we should reserve it for CRE. So this is considered the broadest class of antibiotics. The next question you should ask yourself is, does the antibiotic cover multi-drug resistant Pseudomonas? If so, it is very broad and it should be reserved for multi-drug resistant Pseudomonas. Another question to ask is, does it cover Pseudomonas, period? Because Pseudomonas can select for resistance very quickly, if you are not treating Pseudomonas, you should not be using a drug that's active against Pseudomonas if possible. And the next question is, if a drug covers ESBL Enterobacteriaceae, it should be reserved for ESBL organisms if possible. And lastly, if a drug is more likely to disturb the gut flora and lead to Clostridioides difficile infection, we should use an alternative if possible. Here's a pyramid to help us compare broad and narrow spectrum of activity of antibiotics. So the higher you are on the pyramid, the narrower the spectrum of activity, and the lower you are on the pyramid, the broader the spectrum of activity. Now, I have created a tiering system. So, tier 1, 2, 3, 4, 5, 6 doesn't really exist. I just created this to help us understand and compare different antibiotics when it comes to broad versus narrow. So in tier 1, I would place cefazolin, which is a first generation cephalosporin, and trimsulfa and amoxicillin. And that's because when it comes to gram-negative spectrum of activity, these agents have limited activity, limited to protease, E. coli, and Klebsiella species. Now, these organisms can still develop resistance to this, but in general, the activity of these agents are limited to wild type P, E, and K. Now, in tier 2, I would place drugs like ceftriaxone, which is a third generation cephalosporin, and ampicillin sulbactam, which has expanded activity when compared to amoxicillin. And in addition to protease, E. coli, and Klebsiella, these agents are also more likely to cover Haemophilus and Neisseria species. Now, in tier 3, I will place ertapenem and gentamicin. Ertapenem is the only carbapenem that does not have activity against Pseudomonas, so therefore it is in tier 3 because these agents do not have activity against Pseudomonas. Now, as of 2023, gentamicin is no longer considered active against Pseudomonas, and that is based to updated review of its PK/PD characteristics. So with the safe doses that we use in patients and with the current MIC in Pseudomonas species, gentamicin is not likely to cover Pseudomonas. So for that reason, it has been placed in tier 3, and these agents do not have activity against Pseudomonas, but they are active against ESBL, so that gives them the advantage over tier 2. So if you have Enterobacterales that are producing ESBL, they will essentially be resistant to the drugs beta-lactams in tier 1 and 2. So ertapenem will be drug of choice for ESBL producing Enterobacterales for severe infections such as bacteremia. And gentamicin, of course, is not affected by ESBL since it's an aminoglycoside. And both of these agents also have extended activity against more gram-negative organisms. So Citrobacter, Providentia, Enterobacter, and Serratia. And they do not have activity against Acinetobacter. Now, when it comes to tier 4, this is when we really start to define broad spectrum because of activity against Pseudomonas. So essentially, this is where most experts would agree, where we draw the line between broad and narrow, because Pseudomonas species can develop resistance relatively easier compared to other organisms. So if you are not suspecting Pseudomonas when you're treating an infection empirically, we shouldn't use an agent that's active against Pseudomonas when we have multiple options. So this is literally the beginning of broad spectrum, and these are drugs that are pretty much active against wild type Pseudomonas aeruginosa. So ciprofloxacin, levofloxacin, tobramycin, cefepime, ceftazidime, and piperacillin tazobactam are the most common ones. And I say wild type because, again, Pseudomonas can develop resistance to these agents, but wild type essentially, where these agents will have intrinsic activity against Pseudomonas. And that's why we have a tier 5. These are agents such as the rest of carbapenems. So remember, ertapenem doesn't have activity against Pseudomonas, but the rest of carbapenems do. And also ceftolozane tazobactam. Ceftolozane tazobactam was specifically designed to be having potent activity against multi-drug resistant Pseudomonas. So when Pseudomonas is resistant to drugs in tier 4, that's when these drugs come in. So, we don't really want to use these for all Pseudomonas. We really want to reserve them for when Pseudomonas turns into multi-drug resistant Pseudomonas. So for that reason, these are typically reserved or restricted in hospitals, and they will require approval for use just to make sure that the ID or antimicrobial stewardship team can get a second look and make sure that their use is appropriate, because the more we use these agents, the more likely that we will lose them to resistance. So we really want to use them judiciously. And then tier 6, they are still active against multi-resistant Pseudomonas, but in addition, they also have activity against carbapenem-resistant Enterobacterales. So some Enterobacterales, of course, can develop ESBL, but the smaller portion of them can also develop resistance to carbapenems. So if we have E. coli resistant to meropenem, for example, that's when we want to go to tier 6. So these are really reserved for when we have these difficult to treat organisms. So cefiderocol, ceftazidime, avibactam, and some of these carbapenems combined with beta-lactamase inhibitors. So meropenem, vaborbactam, imipenem, relibactam, and also some other classes. So polymyxins, so polymyxin B and colistin, as well as plazomycin, which is an aminoglycoside, the most recent aminoglycoside, has good activity against these agents. They also have a tier 6B because there are agents that are active against CRE and ESBL, but they actually do not have activity against Pseudomonas. So there are actually a hole in tier 6B, but still these are pretty broad, even though they don't have activity against Pseudomonas, because they are active against CRE. So we really want to reserve these for when we don't have other agents available, because when we get infections due to CRE, we really have limited options. And by the time we get to CRE, it's really easy for these organisms to be resistant to multiple classes of antibiotics. So tigecycline, eravacycline, and amikacin, these are they may have activity against CRE, but they don't have activity against Pseudomonas. So amikacin, just like gentamicin, as of 2023, is no longer considered active against amikacin for systemic infections, based on its updated review of PK/PD characteristics. The only time that it will be okay to use amikacin for Pseudomonas is if it's in urinary tract infections, and that is because a high concentration of amikacin can be achieved in the urine, and that can meet the PK/PD parameters. But outside of the urine, pretty much based on current circulating organisms, MIC, amikacin is no longer considered active against Pseudomonas for invasive infections. One thing I want to mention about Acinetobacter. Acinetobacter is also an organism that can easily develop resistance to multiple classes of antibiotics. So I mentioned that tier 3 doesn't have activity against Acinetobacter. Now, in tier 4, it is depending on the agent, it may or may not have activity against Acinetobacter. And even at tier 5 and 6, even though I have A here in case for Acinetobacter, you really need to check for susceptibility, because Acinetobacter may or may not be resistant to these agents, because again, it's really easy for Acinetobacter to develop resistance to multiple classes of antibiotics. So when it comes to gram-positive, we discussed the risk factors for MRSA. So empirically, you will have an agent like vancomycin or linezolid for MRSA, and once the culture and susceptibility results come back, and if it is MRSA, then we continue vancomycin, and then you can discontinue the antibiotics for pseudomonal coverage. Alternatively, if the results come back and it is not MRSA and it is MSSA, then you should discontinue vancomycin and start the patient on oxacillin or nafcillin or cefazolin, because these are tier 1. These are tier 1 or antibiotics, and you should discontinue any other agent for Pseudomonas. Now, if the patient actually happens to have Pseudomonas, then you should use the results of antimicrobial susceptibility to see which one is susceptible and use it. Now, generally speaking, only one agent is sufficient when it comes to pathogen-directed therapy. Occasionally, you can use 2 agents if the risk of death is high in the patient. For example, septic shock would be an example. So if a patient is still in the ICU on pressors, in order to maintain normal blood pressure, that patient could benefit from 2 agents, even for definitive therapy. Again, it's important to avoid aminoglycoside monotherapy. Even if Pseudomonas is susceptible to aminoglycoside, you should not use aminoglycoside monotherapy. You can only use aminoglycoside as a part of a combination. So, for example, you can use aminoglycoside plus cefepime. Now, when it comes to multi-drug resistant pathogens, you can also add inhaled therapy. So one of the problems is penetration to the lungs. So if it's difficult for many of these antibodies to actually get to the site of infection, so inhaled therapy will actually deliver the antibodies to the site of infection, which is the lung. But inhaled therapy should never be monotherapy. It's always an add-on. So you add it to your IV therapy. So if someone is getting cefepime and IV tobramycin, and you can add inhaled tobramycin on top of it. So inhaled tobramycin is not to replace IV tobramycin. And lastly, if you do have an ESBL agent in the lungs, the guideline doesn't make a specific recommendation, so you can use anything that's susceptible. Now, historically, we have said that carbapenems are drug of choice for ESBLs, and it has been subject to some controversy in recent time. Recently, there was a study, the Merino study, that showed that when it comes to bacteremia, carbapenems are better than piperacillin and tazobactam because it reduces mortality. So my recommendation is to also use carbapenems for pneumonia. But basically, we have limited data when it comes to pneumonia with ESBLs.